Today, okay?
Sounds great.
We're gonna start getting these muscles right back here so you can raise your arm up easier.
Okay, wonderful.
Good? Super. Be quick and brief with your informed consent, right? He doesn't care about the difference in mechanics between the lats and the teres major. Just these muscles right here. Ready? Those three bullets. You got it. Bottom of 117, left column.
Yes. Hand placement and procedure. Grasp the posterior aspect of the distal humerus just above the elbow.
Pause. This is going to be helpful when we start giving tactile cues for our Pnf stretch, our hold relax. I need to be here on the posterior humerus because I'm going to want him to move in the direction of my cue. We're relaxing the arm right here. I don't need for it to be absolutely straight, but I also don't want it to be maximally flexed, because what muscle am I going to stretch if I maximally flex the elbow?
Triceps.
Yeah, the long head of the triceps. So we're just going to avoid stretching the triceps by keeping it out of full flexion. Doesn't mean it has to be fully extended, it just needs to not be fully flexed. And nice and relaxed, right? So posterior distal humerus, arm not fully flexed.
Ready? Stabilize the axillary border of the scapula to stretch the teres major, or stabilize the lateral aspect of the thorax and superior aspect of the pelvis to stretch the latissimus dorsi.
Perfect. So again, that's what we talked about, differentiating teres major from the lats. Your technique is no different than going. We did this before. If you're stabilizing the scapula, we're preventing upward rotation. We're keeping it in a maximally elongated position for the teres major. Just put your hip on your elbow and lean on your patient.
Move the patient's arm into full shoulder flexion to elongate the shoulder extensors.
Perfect. So we're stretching the extensors by doing flexion. Now, I don't like this at all, but for a couple of labs, especially with upper extremity stretching, we have to play imagination. Because how many people lack the flexibility to reach overhead in this room? Nobody. We all have really good upper extremity flexibility. With the legs, we can generally feel most of these stretches, but in this lab, with everybody having normal mobility, we rarely actually stretch a muscle. So patients, you might have to play pretend and role play. On the practical, Mr. D is everybody's patient. He will give you legitimate restrictions. And so as you go to take his arm through the range of motion, you get to a point and you'll be like, oh, I feel tissue resistance. So he'll give you an actual patient on the practical. So we just kind of have to deal with that in here because it's imagination land. So if we're doing a static stretch, this is it. This is a static stretch. How long are we gonna hold? I don't know, at least 10 seconds, 30 seconds, 90 seconds, whatever.
Stretch went away.
Stretch went away. So, as we hold that stretch, the muscle is elongated, pulls on the tendon, increases tension, stimulates the GTOs, responsible for autogenic inhibition. The muscle will relax, and your patient's gonna feel like it goes away. So you might sneak a little bit more as we go through our static stretch. It's important for the patient to feel like the arm is well supported, because he can't hold it up actively or we're not gonna get as deep of a stretch. So kind of hug the arm, right? Got him on my tummy, got him here. Arm is in a really hugged, supported position so that we have a nice limp hand and wrist. If he starts to make a fist, we're not gonna get a very meaningful stretch. So there's our hold, relax, PNF. I'm sorry, there's our static stretch. Hold, relax looks a little different. We take the range limiting muscle to the point of a stretch. Feel the stretch? Where do you feel it?
Right here.
Perfect. All right, we expect him to feel it in his lats. We hope so. We take it to the point of a stretch, and then we wait for it to go away.
Away.
Then our patient's gonna perform an end range, pre-stretch, submaximal, isometric contraction. Mr. E, in a moment, I want you to try to bring your elbow down toward your hip, verbal cue. In other words, move into my fingers for an out loud count of 10. Got it?
Got it.
Go. Submaximal, isometric, end range, pre-stretch. He's trying to bring his elbow down. If I was to let him overpower me, this is what he's doing. I'm resisting that, so it's an isometric contraction. Do 8, 9, 10 again?
Yep, I got it.
Okay. After that, we add a little bit. Feel a stretch in the same spot?
Yes, sir.
Good. With hold, relax. We hold it until the stretch goes away, gone away,
Away.
and then repeat. Biggest mistake on the practical is instead of waiting for the stretch to go away, it's just like rep after rep, rapid fire of contraction. Take a minute, let the stretch come back, let the stretch go away, and then do another rep. We're gonna start with just those 2 techniques for flexion. So you've got the latissimus dorsi, stabilizing here, static, and hold, relax. Teres major, stabilizing here, static, and hold, relax. So 4 total stretches. Good? Okay.
Okay.
Okay. I want you to try to bring your arm as far up overhead as possible
Okay.
until you start to feel a stretch.
Okay, I feel a stretch.
Where do you feel it?
Here.
Perfect. Can I stabilize your trunk to keep it from moving?
Sure.
Okay, so I can come in with some stabilization here or here. If he'll let me, can I hold your arm in place so that you can relax for a moment?
Sure.
Come here and hold his arm in place, but I'm not going any further. Stretch gone away?
Yes, sir.
I'm gonna let you go. You go a little further on your own.
Okay.
Right, so he is gonna be in charge of the quantity of stretch. I'm gonna participate to the extent he lets me, but only by supporting him. Again, giving his arm a good hug so that it feels stable. And lets him rest for a minute. Stretch gone away?
Yes, sir.
Do 1 more. And again, he can either hold it there, or if he's willing to let me, I'll come in and hold it for him. But I'm not adding to the stretch. Last one, hold, relax with agonist contract, is just gonna blend those last 2 concepts. So, just like before, Mr. D, you're gonna bring your arm actively as high up as you can until you
Okay.
feel a stretch.
Feel the stretch.
Same spot?
Same spot.
Good, can I come in and support it?
Please.
There's the agonist contract component. He's in charge. Now, I'm not gonna bring you into any further of stretch.
Okay.
In a moment, I want you to just tire out that muscle a little bit. Try to bring your elbow, here's my tactile cue, down toward your hip for an out loud count of 10. Got it?
Got it.
Go. And then when you get to 10, I'm gonna let you go.
Okay.
And you're gonna go a little bit further if you're able.
All right.
It doesn't need to be dramatic. Just showing you that I'm not bringing it any further. He's in charge, and relax. But the key is that we as the clinicians are not adding to the stretch. Stretch gone away?
Yes, sir.
We're gonna repeat 1 time. And then he's going a little bit further yet. So those are the last 2 techniques to improve flexion. And again, the stretches to improve flexion are for the extensors, which are the lats, we stabilize here, or the teres, we stabilize here. All right, do those 2. For abduction, instead of being right here, all you need to do is move to right here. And now we're abducting. My stabilization hand is unchanged. Lats versus teres. Only difference is I am now moving in the frontal plane. Incidentally, we want to take your patient to his or her full external range of motion. Right? Especially if we're abducting, we know we abduct easier during external rotation than if we're internally rotated. But if your patient is profoundly limited in abduction, they might also be limited in external rotation. So for demo, now I've got him all the way externally rotated. But your actual patient might not have that much mobility. If that's the case, we're going to externally rotate them to wherever they can go. If this is it, this is it. If they can't fully externally rotate though, if they're stuck here, don't go past 90, right? We don't want to create impingement on purpose. We can pass 90 of abduction once they have that external rotation. Okay, so we're picking up with hand placement right in the middle of the page, left column of 118.
Hand placement and procedure. With the elbow flexed to 90 degrees, grasp the distal humerus. Stabilize the axillary border of the scapula and move the patient into full shoulder abduction to lengthen the adductors of the shoulder.
Perfect. Again, this lengthens the adductors that attach to the scapula, and this targets the latissimus. If we just stay static and don't move, it's a static stretch. Again, as he relaxes, we might sneak a few more degrees here and there. We'll do all 3 of our PNF ones here as well. For our hold relax, Mr. D, in just a minute, I want you to gently try to bring your elbow down toward your hip, moving into my fingers, tactile cue to the posterior distal humerus for an out loud count of 10. You ready?
Ready.
Go. And then you're going to immediately relax.
10.
Feel stretch.
Feel stretch.
stretch goes away,
Stretch it away.
we repeat. Cue right there, bring your elbow down. It's a pre-stretch, end range, submaximal isometric contraction to the range limiting muscle, followed by an increase in movement. I'll just keep saying it until...
Block it forever.
Agonist contract. Again, we're going to support him to the extent he'll let us support him. It may be limited, it may be zero. I want you to just actively bring your arm out to the side as far as you're able.
Okay.
Is it okay if I stabilize you here?
Sure.
Good. Okay if I hold that arm in place?
Yes.
Okay. I won't go any further. I'm just going to hold you there.
Okay.
But agonist contract, he is in charge of increased quantity of movement. Stretch in the same spot?
Yep.
Yeah, gone away?
Yep.
Good. So see if you can get a little bit further. I'm not helping. I'm just supporting when he stops. And again, if your patient's not in for it, you can skip that. Hold, relax with agonist contract. We just put them together. You're going to bring your elbow down toward your hip real gently for an out loud count of 10. Then you're going to relax and try to bring your arm actively further overhead. And I'm just going to come in and support. So that's 8 stretches. Right? It's all 4 for the lats, all 4 for the teres. But I imagine everybody doesn't want to watch me demonstrate the same thing 8 times. So we'll take 5 minutes, we'll practice these 4. I am, like the picture, going to stand here at the head of the table facing his hips and feet. But if I am stretching the internal rotators to improve external rotation, I need to stand here facing his shoulders and head. So the picture in the book has the clinician in the wrong spot, because if the clinician was in the right spot, you would just have a posterior view of the therapist and not see what you need to see. So the clinician should be right here where I am, not where he is in the image. So to improve external rotation, stretch the internal rotator splat muscles. And this looks almost exactly like Goni. So during Goni, remember we took a towel roll and we placed it under the distal humerus. Incidentally, when you place your towel roll, don't put it parallel to the humerus because it's easy to fall off. Instead, place it perpendicular so that even if your patient moves a little bit, it doesn't fall off. We placed the towel roll to get the humerus level, but also to make sure that the arm wasn't excessively or hyper horizontally abducted. This position, or even worse, if I put the towel roll here, we don't want that. Which part of the joint capsule is stressed, this kind of tension when we position our patient like this?
The glenohumeral.
Which portion of it though? The glenohumeral joint capsule.
The anterior.
The anterior aspect. There will you good?
Yes.
Okay. There will be patients 3rd semester. There's a lot of shoulder patients we'll see for whom this position is contraindicated. And I'll give you a couple of examples. You don't have to memorize these, I just want to apply the idea so that it makes sense why we're positioning. One patient, for example, had, or will have, a traumatic anterior dislocation of the humeral head. And so that patient's already hypermobile in that direction. Those static restraints, the ligaments, are already overstretched. And so positioning that patient like this, absolutely contraindicated. Another patient's, let's talk, somebody's had a total shoulder replacement. They get this big anterior incision to take out the old hardware and put in new hardware. And they spread open the capsule to change out the parts. And then they sew it back together. But as the capsule is healing, we certainly don't want to stress it by doing this. So there are a lot of specific patients for whom this position is contraindicated. So our stretch is going to try to put the humerus in a relatively level position so that we're not already adding a stress to the anterior capsule. Again, you don't need to remember those specific examples. It'll make sense next semester. It's why we talk about concave convex so much, because concave convex helps us predict movement precautions and restrictions on our post-op patients. Okay, it was a really long segue to say, picture's wrong. Position yourself here. Ready. We're going to read from the bottom 3 bullet points, and then over on the right column, the top 2, and the precaution.
Hand placement and procedure. Abduct the shoulder to a comfortable position. Initially 30 or 45 degrees and later to 90 degrees if the GH joint is stable, or place the arm at the patient's side. Flex the elbow to 90 degrees so the forearm can be used as a lever to rotate the humerus. Grasp the volar surface of the mid-forearm with one hand. Scapular stabilization is provided by the table on which the patient is lying. Externally rotate the patient's shoulder by moving the patient's forearm closer to the table. This fully lengthens the internal rotators.
Perfect. Precaution.
Precaution. Because it is necessary to apply the stretch forces across the intermediate elbow joint when elongating the internal and external rotators of the shoulder, be sure the elbow joint is stable and pain-free. In addition, keep the intensity of the stretch force very low, particularly in patients with osteoporosis.
So lots of good stuff there. I'm giving a force to, the book says volar, but we use the term anterior. Either one is okay. So the anterior forearm is where my force is going to be, especially when I go hold, relax, I'm asking him to push into me. Stabilization, talked about that. When we do internal rotation in a minute, I'm going to need to stabilize the shoulder. But for external, just like Goni, it hasn't changed. Stabilization of the scapula is provided by the table, right? Patient's body weight is compressing the scapula, stabilization coming from the table. Questions about those bullets? No, so let's put all these together. Here's our static stretch. One thing the text did not explicitly mention is with your stabilization, just grab the distal humerus so that we don't create more abduction, just like we did for Goni. No difference there. So static, we're right here. Hold, relax. Mr. D, in just a moment, I want you to push your palm toward me, okay? And go. And I'm giving a contact only to the anterior surface. I'm not like this because that's confusing. Only to the anterior surface. 10, and then relax. If he's relaxing and he's not contracting, grab the whole wrist and forearm. Stretch gone away? Where is that stretch?
Right in front of my shoulder.
Good. But when I'm asking him to contract during hold, relax, I need to give a real crisp, clear cue in only one direction. There's our hold, relax. Agonist contract. Mr. D, I'm not going to touch you beyond holding you right here, okay?
Okey-dokey.
I want you to actively bring your hand back as far as you can this direction until you start to feel a stretch.
Feel a stretch.
Where do you feel it?
Right in front of my shoulder.
Good. Can I hold you there?
Please.
Again, I'm supporting him to the extent he'll allow me. Can you do it again?
Sure.
Good. Bring the back of your hand down toward the floor. Feel a stretch?
Yeah.
Good. Agonist contract. Hold, relax, agonist contract. We put them together. Push into my hand for 10. Contracting the range limiting internal rotators.
10.
And then bring the back of your hand down toward the table. And then you take over and just support. It's all right there. Questions about the techniques to improve external? So that's our basic setup. All right, ready to read.
Good. Hand placement and procedure. Abduct the shoulder to a comfortable position that allows internal rotation to occur without the thorax blocking the motion.
I'm going to interrupt you real quick there.
Yes.
If the patient's has 0 degrees of abduction, we can't meaningfully stretch to improve internal rotation, right? We've got to have enough to at least get it out a little bit. So that's that point right there. We don't want to hit the tummy because that's not a stretch. Our ultimate goal, however, 90 degrees.
Yes. Flex the elbow to 90 degrees so the forearm can be used as a lever to rotate the humerus. Grasp the dorsal surface of the mid-forearm with one hand. Stabilize the anterior aspect of the shoulder and support the elbow with your other forearm and hand. Move the patient's arm into an internal rotation to lengthen the external rotators of the shoulder.
Good, so I want half of you as patients and half of you as therapists, and we're going to walk through the cueing for this together. So, half of you jump down. We'll do another round.
Okay.
Here. And here's our static stretch. We're just going to push from the posterior or dorsal aspect into internal rotation to stretch the external rotators. Once you get to tissue resistance, we're just going to stop. Again, patients, you might have to make believe a little bit. So clinicians, you've got your stabilization flexor carpi ulnaris on the anterior shoulder, your stabilization hand on the medial epicondyle, and you're pushing down into internal rotation. Static, we're just staying right here. For hold, relax. Now, we are going to change our hand placement, and instead of grabbing the whole forearm, we're just going to move to the posterior aspect. And patience, in just a minute, you're going to try to bring the back of your hand up toward your clinician's face real gently for an out loud count of 10. Ready? Push into our hand. Push into our hand, clinicians. You just are contacting the posterior aspect. If you're grabbing the whole forearm, don't. And then after 10, we're pushing down gently a little further toward the table. That's hold, relax. We'll do one more cycle. Clinicians, we're now moving our hand to the posterior surface. Patients, you're going to push your hand back toward our face for a gentle out loud count of 10. After 10, relax, and we're going to go a little further in the direction of internal rotation. Back at neutral. Agonist contract, all I'm going to do is cue my patient to actively bring the palm of his hand down toward the table, and then if he'll let me, I'm going to stabilize him there at end range. So again, we're tapping the anterior surface, give him a tactile and verbal cue, bring your palm down toward the table, and then once you feel a stretch, I'm just going to support you. All client, AC, it's active, good for patients who don't want you to touch them. So all we're going to do is support them. We're not going to push into any new movement. And then if we were to blend this with hold, relax, agonist, contract, all we're going to do is take the last two and put them together. We're going to push back toward our face actively for an out loud count of 10. And then patients on your own after 10, bring the palm of your hand down toward the table. Good. Once you feel confident with that, trade places with your partner. We'll run through those